Okay, so welcome everyone to this ASH Health Inequalities and Smoking webinar. You can hopefully all now see my screen. There we go. So my name is Robbie Titmarsh. I'm a policy officer here at ASH. I'm going to be chairing today's webinar. I'm just going to run through a couple of points on housekeeping before we get going. So you can see the agenda on the screen now. So we've got today our Chief Executive at ASH, Deborah Arnott, and then we're having Dr. Sarah Jackson from UCL. And then I'll be doing a quick overview of the Health Inequalities Resource Pack before we have a good bit of time for questions and answers at the end. So on questions, you should see on your right-hand side panel, you'll have a questions tab. And in there, you can just enter any questions you might have throughout the webinar. You can send those at any time, and we'll receive those. No one else will be able to see them, so you don't need to worry if it seems like they're not coming through or no one else asking questions. We'll collate those, and then I'll be putting those to Deborah and Sarah at the end of the webinar. Ask as many questions as you like. If there are any that go unanswered, we'll answer them sort of after the webinar and circulate the answers, and we'll upload those to the website, so you'll be able to see those. We'll also be recording the webinar, and again, that will be uploaded to the ASH website afterwards, so you'll be able to review this, share it with your colleagues and everything. And then, should you have any technical problems throughout the webinar, hopefully that won't be the case, but you'll see a chat panel on the right-hand side. You can enter any messages there, and we'll keep an eye on those and try and resolve that for you, but hopefully everything should run to plan. So, without further ado, I'm going to pass over to Deborah, who's going to be talking about a bit of an overview of the policy relating to health inequalities and smoking. So I'll hand over controls now. There you go.
This is my first time as on the webinar, and I'm doing this because unfortunately Sarah Williams from Public Health England was unable to because of the general election being called. And many thanks to Sarah for a lot of the input to the slides. Any mistakes will be my own. So, first of all, how do I move on? Yeah, it's not moving. This is me, I apologise. I'm just getting up to speed on this. It doesn't seem to be, yeah. Ah, great. Thank you, Vicky. So, first of all, at an overview, health inequalities are preventable and unfair differences in health between different groups of people or communities, and patterns in smoking uptake and quitting behaviour are highly marked by social inequalities and disadvantage, as I'm sure you all know. So, smoking remains the greatest cause of health inequalities, and as a result, richer smokers have a lower life expectancy than poorer non-smokers, but because, and the life expectancy is similar for smokers, but because smoking rates are so much higher in poorer smokers, the inequalities caused by smoking are very significant, and it's due to, it's responsible for half the difference in life expectancy. So 1 in 4 people in routine and manual occupations smoke compared to 1 in 10 in managerial. And in smoking rates among women of childbearing age, the rates are highest in young, white, more deprived populations. And smoking prevalence is particularly high in adults with serious mental illness. And even in areas with relatively low smoking prevalence, smoking in those with serious mental illness remains high. There are lots of other affected groups. Sarah Jackson's going to go into more detail on this, so I won't talk a lot about it. And obviously, the data is better in some cases than others. So, for example, the most recent data we could find on smoking prevalence in Gypsy, Roma, and traveller communities was from 2004. The Tobacco Control Plan for England in July 2017 set targets, but on inequalities, all that it said was that the inequality gap needed to be reduced, and that there should be parity of esteem for those with mental health conditions. And we didn't feel this was sufficient, and we've been pushing for more on that. There are what's called golden threads between reducing inequalities and improving NHS sustainability. And what we need is a whole system approach, which is why with the RCP we pushed hard for the inclusion of smoking cessation in the NHS long-term plan. Although we were disappointed it's not going to happen immediately, by 23-24, all inpatients will be offered tobacco dependence treatment, as will expectant mothers and their partners, and there will be a new universal smoking cessation offer for those being treated by specialist mental health services. The NHS is due to be setting out specific measurable goals for narrowing inequalities, although we haven't seen those as yet. Then earlier this year, in July, we saw the publication of the Prevention Dream paper, and this was a major step forward from the Tobacco Control Plan for England in setting an ambition to go smoke-free by 2030, and a recognition that the tobacco industry should be made to pay. However, what it didn't do was give specific targets for inequalities, although the smoke-free ambition was defined in the Tobacco Control Plan for England as 5% or less smoking rates. And our belief is that has to be across all communities. So in our Prevention Green Paper submission, we set out a sort of roadmap in some of the key groups. And what you can see is that amongst the general population, we're pretty near having the reduction in smoking rates that we need. And also amongst 15-year-olds, which is the sort of upper end of child smoking rates. All smoking is now at 11.4%, and on current trends, we could expect it to get below 5% by 2030. However, for routine and manual workers, for those who've never worked, for those in social housing with mental health conditions, and for we can expect we need to see a much faster rate of decline. And the problem with smoking at time of delivery is that although the target is for 2022 is not that ambitious, actually we've seen very little decline in recent years, so it needs to be the rate of decline needs to get going again. I wanted to talk just a little bit about vaping and health inequalities, because the use of e-cigarettes has changed in recent years, and vaping now follows the same social gradient as smoking, whereas initially we saw an early adopter phenomenon where more people in managerial and professional classes were likely to vape than those in routine and manual groups. We're now seeing actually the same social gradient as the smoking, which could have a positive impact on health inequalities if vaping is used to help people quit. And seeing what we know about the evidence that it's an effective quitting aid. And saving money is a key motivation for people in taking up vaping, particularly in lower socioeconomic groups. However, perceptions of harm need to be addressed. Sorry, that's moving on too fast, because what we know is that the perceptions of harm amongst lower socioeconomic groups is worse than for the general population, and throughout all groups, there are misperceptions about the relative risk of smoking and vaping, which have not been helped by the outbreak of serious lung injury in the US, even though that's associated with vitamin E acetate. Vitamins are banned in e-cigarettes in the UK, and with vaping cannabis rather than tobacco, nicotine rather. One of the other things that could be key to tackling inequalities is illicit trade, because what we know is that affordability is key to quitting. I mentioned it above in vaping, and access to illicit tobacco, which on average is around half the price of legal tobacco, is much more widespread in poorer socioeconomic groups. So, what are our next steps when it comes to the Prevention Green Paper? The consultation finished on 14th of October, and in principle, the government should be publishing its response to the consultation within 12 weeks, or provide an explanation why this is not possible. That would take us to the 6th of January. However, with the general election and Christmas, we think it will take much longer than this. And also, the Prevention Green Paper covered everything, really, all issues in prevention, not just smoking. We want to actually separate out tobacco and the ambition for a smoke-free 2030, and encourage the government to deliver what's necessary for that. Becoming smoke-free by 2030 will be, as the government itself admits in the Green Paper, extremely challenging. And we need to get commitment, not just for a headline rate of 5% or less, but for all these disadvantaged groups. We also need better funding, because the things that will actually really help us to reduce smoking in more disadvantaged groups need funding. We're talking about things like more extensive public education campaigns, which has been slashed drastically over the last decade and has led to a decline in attempts to quit. Improved access to smoking cessation support, not just in the NHS, but also for all smokers, and enhanced enforcement to reduce the illicit trade. This is key to reducing affordability in poorer communities. And while HMRC has a well-funded strategy, trading standards funding, as many of you will know, has been significantly cut in recent years, and that has reduced the ability for localities to enforce tobacco regulations and tackle illicit trade. So in the new year, we need to keep pushing the government on delivering on its commitments in the Green Paper on tobacco, which are for a smoke-free 2030 ambition, for a polluter-pays levy to be consulted on, and to publish further measures to reduce smoking. And there are various other things we can look at, but the first two are the priority, and that's to commit to delivering on that ambition and providing the funding through a levy on the industry. Thank you very much.
Thank you very much, Deborah. For that presentation. I'm going to take back over control there. So, just a quick reminder for everyone.
Vicky, how do I get that?
If you have any questions throughout the webinar, please do post them in that questions panel.
It's not come up. I don't know.
I don't think we're seeing my screen. Can you find show my screen?
Okay, sorry. So back on track now. So yeah, just a reminder for everyone, if you do have any questions throughout the webinar, please do post them in that questions panel, because we'll have plenty of time for questions and discussion at the end. So yeah, do not hesitate to do that. I'm going to now pass over to Dr. Sarah Jackson, who is a Senior Research Fellow at the UCL Tobacco and Alcohol Research Group at University College London. So, Sarah, I'm going to pass over the control to you now. I'll let you take it away.
Hi, so hopefully you can all now see my screen. As Deborah mentioned, both smoking uptake and also quitting are highly patterned by social inequalities or disadvantage. So in this talk, I'll outline the latest trends and patterns in smoking-related health inequalities, taking a look at where we've come from and where we're headed. I'll outline some of the factors that contribute to these inequalities, and I'll discuss the current evidence for effective interventions and approaches to reduce smoking-related health inequalities. So when we're talking about disadvantaged groups in the context of health and smoking inequalities, what exactly do we mean? Deborah mentioned a few of them in her talk. So socioeconomic position refers to the position that a person occupies in the structure of society due to social or economic factors. And groups considered to hold a more disadvantaged socioeconomic position include people from low-income households, or working in routine and manual occupations, people with mental health conditions, people in contact with the criminal justice system, members of the LGBT community, people experiencing homelessness, and it also encompasses people from other minority or excluded groups such as ethnic minorities, or people with multiple needs, for example, those experiencing homelessness, substance abuse, and mental health problems at the same time. And globally, the disadvantaged groups are substantially more likely to suffer disease, disability, and premature death than people with greater advantage. And one of the key drivers of these is the fact that these groups are also much more likely to smoke. And because smoking is so uniquely harmful, any differences in smoking prevalence across the population inevitably translate into differences in health. So let's have a look at some of the recent data on smoking inequalities. The available data overwhelmingly focus on socioeconomic position. This graph shows smoking trends in manual and non-manual workers in Britain since the early 1970s. And it's clear to see that while smoking rates across all socioeconomic groups have declined over the years, large inequalities remain and have widened significantly in the last decade. The most recent official data from the annual population survey shows that in 2018, smoking prevalence was 2.5 times higher in people from routine and manual occupations than managerial and professional occupations. And this pattern isn't just seen for occupational social grade, but for each of the disadvantaged groups I mentioned. Smoking prevalence is particularly high among people who are homeless or in prison at around 70 to 80%. And importantly, many people belong to multiple disadvantaged groups, and cumulative disadvantage really ramps up the likelihood that they'll smoke. This is illustrated nicely with data from the Health Survey for England. So in a sample of more than 88,000 adults in England, the authors of this study looked at the extent to which having multiple indicators of low socioeconomic position was associated with different rates of smoking. They took into account occupation, neighbourhood deprivation, lone parenting, car availability, housing tenure, income, and unemployment. And they created a score ranging from 0 to 7 that reflected the number of these different indicators each participant reported. And the results show a very clear gradient in smoking with increasing disadvantage. In fact, not only was smoking rates 4 times higher among the most disadvantaged group compared with the most affluent group, but the prevalence of smoking increased with every additional indicator of low socioeconomic position by approximately 5% for the first 4 indicators, an additional 10% for those with 5 indicators, an additional 15% for those with 6 or 7 indicators, resulting in a markedly high rate of smoking among people with multiple indicators of disadvantage. So what are the factors that contribute to these disparities in smoking? The first, smoking is transmitted through generations. So young people from disadvantaged groups are much more likely to be exposed to smoking and as a result more likely to try it themselves. If a person grows up around smokers, the risk that they too will start smoking is much greater. And children and young people who live with parents who both smoke are nearly 3 times more likely to become smokers themselves than their peers who don't live with smokers. This figure shows the results of 24 studies that looked at the association between having a mother who smoked and uptake of smoking in childhood and adolescence. And overall, these show that the risk of becoming a smoker is more than doubled if the mother smokes. Another factor that may increase smoking in disadvantaged adolescents is the inability to resist peer pressure and an increased level of peer pressure given that more of their peers are likely to smoke. So the influence of social connections on smoking reflects a mixture of different factors. Role modelling and social norms might lead disadvantaged youth to perceive smoking to be normal behaviour, which reduces obstacles to experimentation. And in addition, in being more exposed to other smokers, they may actually have greater access to cigarettes and tobacco. And this increased access may extend beyond the home and school environments to the wider community. Several studies in high-income countries have shown that deprived communities have more access to cigarettes through relatively higher numbers of cigarette retail outlets and higher levels of tobacco advertising and promotion. For example, this study in the US found a higher concentration of tobacco retailers in areas with higher proportions of Black residents and those from lower incomes. And similar results have been observed in another study that looked at the proximity of tobacco outlets to US schools, with outlets more densely concentrated among schools with higher representation of ethnic minority and low-income students. And given that both marketing placement and targeting influence smoking uptake, there seems to be sort of scope for banning tobacco company advertising, reducing smoking inequalities. So it's clear that there are several reasons why disadvantaged groups may be more likely to take up smoking. But if we look beyond uptake, there are other factors that may perpetuate smoking and discourage cessation. Smokers who are trying to quit benefit from continuing non-directive social support, which may be harder to find when smoking is more common and more acceptable within your family and community. Long-term abstinence is also harder for ex-smokers if they routinely find themselves in the company of smokers, especially if they experience social pressure to smoke. People from disadvantaged groups tend to be more focused on the present and are more likely to be motivated by immediate health concerns. They may be less likely than more affluent people to be motivated to quit by a concern for future health, which may undermine any desire they have to quit. In addition, quitting smoking is really challenging, and it typically involves a concerted effort. For any smoker who's struggling to cope with life on a daily basis because basic socioeconomic or psychosocial needs are unmet is unlikely to see quitting as a priority and may consider smoking to be vital to everyday coping and stress relief. Putting this in the context of Maslow's hierarchy of needs, one could argue that smoking cessation falls within the bounds of self-actualization and achieving one's full potential, while for disadvantaged smokers, priorities lie firmly in meeting basic physiological and safety needs. And strong evidence shows that even when disadvantaged smokers are motivated and try to quit, they're less likely to be successful than more affluent smokers in stopping smoking completely. For example, a study of over 50,000 smokers in England found that smokers who live in social housing who try to quit are only around half as likely to be successful as those living in other housing tenures, such as homeowners and those who rent privately, despite being significantly more likely to use evidence-based cessation support. For example, behavioural support, prescription medication, or e-cigarettes. And the same is seen when we stratify users of NHS stop smoking services in England by occupational social grade. So each year, quit success rates are higher for smokers in managerial and professional or intermediate occupations who try to quit than they are for smokers from routine and manual occupations, despite getting the same support. So what can we do about this? As Deborah mentioned, the Tobacco Control Plan for England calls for targeted action to address smoking inequalities. And it emphasised the need to identify groups and areas with the highest smoking prevalence and take focused action to reduce smoking-related health inequalities. There's good evidence on what's effective in reducing adult smoking. As you've seen, we've made great progress in reducing population smoking prevalence substantially over recent years. On a population level, there's good evidence that smoking prevalence can be reduced by a range of measures, including increasing the price of cigarettes, implementing legislation that prohibits smoking in public places, and investing in tobacco control mass media campaigns. Although it's hard to show conclusively, circumstantial evidence suggests that banning tobacco advertising and putting large graphic health warnings on cigarette packets also helps to reduce smoking prevalence. And on an individual level, stop smoking services or receiving brief advice on cessation from a health professional can increase quit attempts and cessation rates. And there are effective cessation aids that increase the chances that a quit attempt is successful, including prescription medications, varenicline and bupropion, behavioural support, nicotine replacement products, and e-cigarettes. But if we go back to the trend data, it's clear that while smoking prevalence in the UK and other development countries is declining, the social gradient in smoking is not. And this is really important because we need to reduce the gap between more and less advantaged groups in order to reduce the resulting inequalities in health. And although we have very good evidence on what works to reduce smoking, what is less clear is how we close the gap between those who are less versus more advantaged. The studies have examined the extent to which these different interventions are more or less effective in helping disadvantaged smokers to quit. The clearest and most consistent evidence of a positive equity impact is seen for increasing the purchase price of cigarettes. Smokers from more disadvantaged social groups tend to be more responsive to price or tax increases compared to more advantaged smokers. So as the cost of smoking increases, many people, in particular those with low disposable income, respond by cutting down. But simply raising the price isn't sufficient because there are a number of strategies that smokers can use to absorb price rises while maintaining their usual intake of nicotine, including switching to less expensive products, for example, roll your own tobacco, buying illicit tobacco, or reducing the number of cigarettes per day, but smoking them harder so they achieve the same exposure to nicotine and the associated chemicals that cause a risk to health. Smoking bans may also have a positive equity impact, but only if they're applied universally. Studies tend to show that voluntary, local, or regional smoke-free policies may actually increase inequalities in both smoking prevalence and exposure to secondhand smoke. But legislated smoke-free environments remove the inequalities in protection from secondhand smoking and level the playing field across more and less advantaged areas. The evidence from mass media campaigns is mixed, and their effect on smoking inequalities likely varies according to the type of media message, the media format, and the mechanisms of engagement. For example, a campaign that was found to be successful in enhancing equity was one that offered free NRT products to smokers wanting to quit in a jurisdiction where NRT wasn't freely available. Controls on advertising, marketing, and promotion of cigarettes, including warning labels, have been found to have mostly neutral equity impact. So that is, they don't increase or reduce smoking inequalities. Moving on to individual level interventions, stop smoking services appear to be effective in reducing smoking inequalities. The studies have shown that NHS stop smoking services reach proportionately more smokers in disadvantaged areas than elsewhere, which more than compensates for the fact that there are lower quit rates among the disadvantaged smokers. And this produces a net effect of a higher proportion of disadvantaged smokers quitting successfully with the help of stop smoking services. GP brief interventions have been found to be equity positive in terms of identifying disadvantaged smokers and encouraging them to quit. The disadvantaged groups have been found to be more likely to have their smoking status recorded, be offered brief cessation advice and or referral to stop smoking services, and more likely to be provided with cessation medication. With regards to the specific cessation aids available, there's no evidence that these are either more or less effective in disadvantaged smokers, although use of NRT is more common and use of e-cigarettes is slightly less common still among disadvantaged than advantaged smokers, which may affect the equity impact. And for each of these individual level interventions, increasing delivery to and uptake by disadvantaged smokers could help to reduce inequalities. We know that disadvantaged smokers tend to be more heavily dependent and find it harder to quit, so ensuring they get the right support is essential. It's been suggested that we might be able to boost cessation rates in deprived groups by tailoring smoking cessation interventions to participant characteristics, relating to their lives and addressing specific obstacles they need to overcome to achieve their desired change. However, there's not currently strong evidence that tailored interventions are any more effective in helping disadvantaged smokers to quit than non-tailored support. A large review of smoking cessation interventions for disadvantaged groups, which will be published next week, found that disadvantaged smokers were around 56% more likely to quit successfully with the help of an intervention, such as brief advice or telephone support, but there was no notable difference in success rates between tailored and non-tailored interventions. So while this doesn't imply that tailored approaches should be abandoned, it highlights the need for further investment into targeted interventions that are effective in increasing quit rates for disadvantaged smokers. There's more work to be done here. On a broader level, initiatives to effectively drive down smoking inequalities may go beyond traditional tobacco control policies. To date, the policy response has been to increase investment in conventional approaches to tobacco control, extending the range and intensity of interventions acting on the individual level's influences on smoking. But a review that examined pathways of disadvantage and smoking trajectories suggested that this might not be enough to really tackle smoking inequalities. This paper showed quite convincingly that smoking status is influenced not only by current circumstances, but by longer-term biographies of disadvantage, as they put it. So looking at cumulative life course disadvantaged in women, they observed a clear increase in the prevalence of ever smoking in women who'd been disadvantaged in childhood and had left full-time education at an early age and had become a young mother and had experienced adult disadvantage. And this same pattern was seen for current smoking prevalence, heaviness of smoking, and the reverse was seen for quitting. This paper also showed that key social predictors of smoking status, including childhood circumstances, educational levels, and adult circumstances, are shaped by social and economic policies. So this suggests that social policies are in and of themselves tobacco control policies. And if this is the case, policies that level up opportunities and living standards across the life course have an important part to play in reducing smoking inequalities and its associated disease burden. So a few take-home messages based on the current evidence. The UK tobacco control climate has been effective in reducing smoking prevalence, but not smoking inequalities. We know that disadvantaged groups are more likely to take up smoking and less likely to quit. There are a broad range of population level and individual level interventions to reduce smoking, but few are equity positive and the majority don't reduce inequalities. Tailoring interventions is a strategy thought to be helpful in boosting success rates for disadvantaged smokers, but tailored programs are not yet proving to be more effective than non-tailored interventions, suggesting there's much more to be done in finding the optimal way to support disadvantaged smokers to quit. Thank you very much.
Okay, thank you very much, Sarah. That's really, really interesting. I'm just going to pass control back to myself now. Okay, so once again, thank you, Sarah. Really, really interesting presentation there, and I've had a few questions coming in now on that, and so should make for a really great discussion later. But of course, do keep sending them in, and as I said, do send as many as you like. We'll be able to answer any that we're not able to come to in this webinar afterwards, and we'll be circulating those answers, so don't hold back on your questions. So I'm going to, just in a sec, run you through our newly updated, rather, Health Inequalities Resource Pack. But before I do, just sort of another point, throughout this, this resource pack is sort of intended as a practical resource, largely for local authority public health teams. So if anything sort of struck you throughout this webinar, or if anything strikes you when I take you through the resource pack as sort of you thinking, well, there's a gap there or something else that you'd find really helpful, please sort of do let us know, and I'm going to share our email address to contact us on at the end, because we'd really love to hear from you on that, and it's only going to help us and hopefully help us help you with resources and things. I've also just another sort of point, and I'll reiterate this at the end, but we're really keen to hear from any localities or areas that are working with population groups that are subject to really high smoking rates. So a few that we've heard of today. So GRT communities, that's Gypsy Roma traveller communities, homeless groups or key migrant groups in the area. Anything like that we'd be really interested to hear about. So do please pass that information on to us. And again, I'll share our contact address at the end so that you can let us know about that. So yeah, the Health Inequalities Resource Pack. I will hopefully move the slide on. Okay, so this was originally launched in 2016, and at that point we launched it with support, so like development and endorsement of the Faculty of Public Health, the Association of Directors of Public Health England, and Fresh. But along with those, each of the briefings, as you'll see, sort of look into a range of areas, and so we're keen to sort of ensure we're getting the right framing and language on these and the right hitting the right points. So we've been to a really huge range of organisations on this, and they've helped us develop them and have given us their endorsement both in 2016 and this time with the update. So a big range of organisations that you can see on your screen there. that have really been invaluable in developing these resources. So what is actually in the resource pack? So what we've got, I'll show you in just a second on the website, but we've got a range of condensed sort of two-sided briefings which set out the sort of problem and the solution for local authorities to take in a range of key areas. So looking at groups that we've heard about today, so looking at low-income households, and that's the sort of broad socioeconomic groups and disadvantaged, people in contact with the criminal justice system, people with mental health conditions, looking at people with multiple needs. So that's sort of looking at all the intersecting factors and sort of real build-up of situations and wider socioeconomic factors which can lead to smoking and really exacerbate it. Long-term conditions, smoking in pregnancy, smoking in the LGBT community, and smoking amongst homelessness. Or homeless populations rather. We've also got a couple of new briefings in there. So some of you might have seen our sort of more in-depth smoking and ethnic minorities briefing. And we've turned that for the resource pack into a more condensed briefing on this. So sort of taking the key points, which is looking at actual patterns of use amongst ethnic minorities in the UK, and also looking at sort of different types of tobacco that are used, so looking at water pipe use and also smokeless tobacco and the kind of patterns of use there and the sorts of approaches we might think about taking to effectively supporting people to sort of move away from those products. We've also got another briefing on price and affordability, and that's again sort of looking at the financial impact of tobacco and tobacco addiction on people, and also illicit tobacco, how that drives health inequalities, but also how these things can be leveraged to help people to quit. So using price as a quitting motivator, looking at some of the approaches there, so around engagement through financial and debt advice services, and also a bit of myth busting around sort of arguments you'll hear from the tobacco industry on this. So I think some really great stuff in there. And we've also got just a general collation trying to make the Health Inequalities Resource Pack a bit of a one-stop shop for ASH's resources on health inequality. So looking at some of the broader things we've done around housing and some of our tools and calculators around poverty and things like that. So hopefully really helpful. So we'll have a look at the resource pack now. I'll show you where you can find it on the website. So you can see on my screen here, this is the ASH homepage. So this is just ash.org.uk. And if you go up to the local toolkit here on our bar, which is also a very good resource, and I'd hope you would all have a look at this as well. We'll actually be uploading this webinar just in this section here on the webinars, so you can take a look at that there. It should be up by the end of the week. So the Health Inequalities Resource Pack, just in the top left corner here under Tools and Resources. So I'll click into this. And you can find here, so we've got a bit of an introduction and about some of the things I've run you through today. The introduction is sort of a framing for the toolkit and just, trying to set the context for it in terms of, tobacco addiction and not lifestyle behaviors and things about that. So I think some really helpful framing in there actually and guidance on this. And then in terms of the actual resources and briefings, you can see we've got our actual in-depth health inequalities and smoking briefing has been updated as part of this update. So if I just click into that, this sort of runs through a lot of the key academic literature, national policy as well. So we've sort of updated this with all of the latest things we have, and a lot of information on the various affected groups and so on. And then moving back to the actual resource pack, we've got all of the condensed two-sided briefings, as I said here. So click into one of the new ones here. So this is the ethnic minorities one. And as I said, just sort of really condensed key information on this issue and sorts of things local authorities can be doing to support the particular group in question, depending on the briefing. I think these really serve as great briefing materials for colleagues and counsellors as well. So I think a lot of really great information there. And then moving a bit further down, we've got the tools and resources section. And this is just going to be a sort of growing growing bit of the resource pack, which is just going to contain links through to all of the ASH resources relating to health inequalities and anything which might help you in this work. So, moving back to these. So, yeah, thank you very much. And do please send any thoughts and feedback on the resource pack to that admin address. And also, as I was saying, love to hear of any work that localities are doing around this, working and engaging with any of the groups mentioned in the resource pack, or any groups in your local area which you have identified as having really high smoking rates. We'd be really interested to hear about that. And yeah, thank you very much. So we're now going to have a bit of a question and answer session with Deborah and Sarah. So I'm just going to bring them back on volume-wise. So we've got a few questions that have come through, which I'm going to have a look at here. So do keep sending the questions through as well. There's no time limit on that, so keep them coming in. So let's have a look at what we've got here. So maybe a good one to start with, actually. This is for Dr. Sarah Jackson. Could you explain what is meant by tailored interventions for disadvantaged groups?
So by this we mean taking a sort of traditional intervention that would be offered to anyone and trying to make it address some of the key issues that might be faced by more disadvantaged smokers. So if that's people with mental illness, for example, it might be sort of accounting for the fact that they might find it difficult to attend all of the sort of follow-up and interactive support sessions, so offering things like home visits to account for that, or just finding ways to get around some of the obstacles presented by the other challenges that they're facing to ensure that they're sort of able to engage as fully as possible with the whole of the smoking cessation intervention.
Okay.
Could I add to that, Robbie?
Yeah, of course, please.
Because Sarah mentioned the point that actually smoking cessation isn't in line with the inverse care rule, which says that for most medical interventions, the better off you are, the more likely you are to have good access to it and to use it. So, and I think that's partly due, my assessment would be it's partly due to the fact that smoking cessation services were first introduced in health action zones, and right from the very beginning they were targeted at poorer and more disadvantaged areas and poorer and more disadvantaged smokers. But it's important to sustain that access, and while a tailored intervention there may not be good evidence for it, I think it is important to try and make sure that you're offering those services where people are, which is why the work which Sarah helped us with on social housing is so important. And actually, if you look at the evidence from the e-cigarette pilot in Salford, where people living in social housing and housing association properties were offered access to e-cigarettes to help them quit. It was very successful, and that was an example, I think, of not so much the intervention itself being tailored, but actually looking at how you can make sure that access is available to the widest possible group of more disadvantaged smokers. I don't know what you think, Sarah.
Yeah, absolutely. And I think the reviews that I mentioned that has found sort of no real benefit of tailoring, I found that just giving disadvantaged smokers any sort of intervention does seem to help them quit, but it's helping them to access it in the first place that, as you say, is very important. So engaging people and getting them involved in something is sort of the priority, and then whether tailoring can help enhance it further is something that we need to sort of look into further.
Thank you both. Really interesting. I think whilst we're still on actually tailoring and interventions, and in particular, again, Sarah, just on that paper that you were presenting, someone's asked, where does the Scimitar trial fit into the measure of successful interventions for disadvantaged groups? Do you know if it was included in that paper?
I'm not sure off the top of my head. I think given the publication date, it should have been. But what we were looking at in that paper, so this has been done by some colleagues of mine at UCL, the way they've analysed it is to meta-analyse. They've grouped together all the tailored interventions out there So within those, some of them will have proven to be more effective than the standard interventions. Some of them will not have. And overall, on average, they were found not to be significantly more effective. But that doesn't mean that each individual one wasn't. And we know that the Scimitar trial has shown some quite promising results in tailoring cessation intervention to people with mental health conditions. So that's what I think they were being quite careful about in their sort of recommendations and their conclusions, is that just because overwhelmingly the data at the moment don't support tailored interventions as being more effective, that doesn't mean that they can't be if they're done right. And it just needs more attention and more sort of thought about how we can make tailored interventions more effective for people from more disadvantaged groups.
Okay, thank you very much. Okay, so maybe one for you, Deborah. This is on taxation. So someone's asked, is there a risk that increase in price leads to some having to make a choice between food and heating, so basic needs, and smoking, which could also be seen as a basic requirement, pushing them further into poverty?
Yes, there is a risk, and that's why when we push for reductions in affordability, which are the most effective measure in reducing smoking prevalence and have a bigger impact on youth and people with less income, at the same time, it's got to go hand in hand with doing everything we can to support more disadvantaged smokers to quit, because the impact of that on the household, if they don't quit, is going to be significant. So yes, it is a risk, but that doesn't mean you shouldn't do it, but you've got to do it within the context of doing everything you can to support poorer and more disadvantaged smokers to quit.
Thank you. I think really good answer there. So another one sort of on illicit tobacco here, and I'll put this out to either of you. So aside from increasing the price in the legitimate market, something HM Treasury does, so there is an interesting correlation between lower socioeconomic status and access to thriving illicit tobacco markets. Should more be done by local public health teams as well as central government funding for trading standards to tackle this?
Can I come in there, Robbie?
Yeah, absolutely.
Yes, I mean, what enforcement does is tackle the supply end. What public health teams working with enforcement colleagues can do as well is to try and tackle the demand end, and that's something fresh in the North East with its Keep It Out campaign, which is also being run by Greater Manchester Health and Social Care Partnership and has been run across the north of England in the past, has done quite effectively, because reducing the demand plays a key role in this, and actually making it less acceptable in certain communities to buy illicit. I mean, when the size of the illicit market was at its peak in the early part of this century, when 1 in 5 manufactured cigarettes smoked was illicit and over 60% of hand-rolled, I had a friend who worked for the Red Cross, and illicit tobacco was being sold in the canteen at lunchtime. It was widely acceptable. It has become less and less acceptable, but it is still likely to be more acceptable in poorer communities. And so reducing its acceptability is quite important, and the messages that seem to work most effectively aren't around crime syndicates or terrorism, which are some of the messages people have tried in the past, but around youth access, that if you buy illicit tobacco, these people will sell to anyone, they'll sell to children, and you're supporting greater accessibility to cheap tobacco for children.
Thank you. Okay, so another one for Dr. Jackson here. So the question is there any evidence for the use of social networking approaches in enabling switching to vaping? So the person in question is looking at the potential for using social networking, real world, not online, alongside a financial incentive on social housing estates aiming to achieve rapid, significant uptake of vaping through network effects. So is there any sort of evidence on this, or is this anything you're aware of?
Not anything that I'm aware of, but sort of theoretically I can see how that would be effective. I mean, we know that smoking is a very socially contagious behaviour, so you're much more likely to smoke if other people around you smoke, and much more likely to quit if other people you know quit. And the same does appear to be true for e-cigarettes as well. So in studies that we've done, we've found that people who are regularly exposed to vaping by other people are more than twice as likely to vape themselves. So maybe this same sort of social contagion effect for vaping. And if people can see other people they know who have been smokers switch effectively to vaping, find it relatively manageable to quit smoking and switch completely to e-cigarettes, that could be quite motivating in helping them see that there is a sort of achievable way out of smoking that's not going to be more expensive or much more challenging than traditional options that they've tried.
Brilliant, thank you. Okay, and another question here for Deborah. So this is on the tobacco levy. I should just say before this, it could get slightly technical. So we will share the ASH and Breathe 2025 submission to the Green Paper after this, because there's a lot of detail in there on this. But maybe just in a summary, Deborah, how do you envisage the tobacco levy working? And are there any lessons being learned from the sugar tax, which hasn't been effective as hoped? So how will this go further to get sufficient funds and make a difference?
I am going to answer that question, but I'd first like to ask the question about the social housing report and whether it's led to significant levels of interest action in the social housing sector, because I think that follows on from some of the other questions. And just to say, the answer is yes. Certainly very recently in Lambeth, we know that they're looking at poverty reduction, and using social housing as a way of reaching smokers is something that they're looking at, and that comes out of the social housing report. And that also links back to what people were saying before about the issue of if you carry on smoking, then it increasing the price exacerbates the impact on poverty, and that's something we're very well aware of. And we think that actually using housing to try and reach smokers better, because people used to say that smokers are hard to reach. They're not hard to reach. We know where they are. You have to go out and find them, is my answer. And Lambeth is just one example, but obviously in Greater Manchester this is happening, and in other parts of the country we're seeing it happening. And tobacco control leads are telling us that this has been a way to engage housing. The data, everyone knew that you're more likely to smoke if you're poor, so obviously there's going to be more smokers in social housing, but actually having the actual data has really helped engage housing in thinking about what more they can do. So that's my answer to that question. And then I'll move on now to the levy. And yes, lessons have been learned from the sugar tax. This is not a tax. That's the main point. It's a charge on the industry using mechanisms which were set out in the Health Act 2006 for what's called the pharmaceutical pricing scheme, whereby the Department of Health raises money from the pharmaceutical industry on the cost of prescription proprietary drugs, which can then be used in the NHS. So that mechanism isn't a tax, because actually the government, prior to 2015, the coalition government consulted on a tax and decided not to go ahead with that. This is different. It would be something overseen by DHSC, not by the Treasury. It would set a fixed amount to be raised from the manufacturers, and it would be raised by DHSC and spent by DHSC and Public Health England with the help of an advisory panel. And as Robbie said, more detail on how that would actually work is set out in our consultation response. So I would suggest looking at that. But the key thing to remember is this isn't a tax like the sugar tax. The sugar tax actually had some beneficial effects because it changed the behaviour of manufacturers, but it didn't raise the money that was expected because their behaviour changed. With cigarettes, what we want to do is raise a fixed amount of money, and that's why it's a charge, not a tax.
Thank you, Deborah. I think really helpful on that. So just rewinding a little bit back to illicit tobacco, is there any evidence to show that work done at regional level has an impact on the supply and demand of illegal tobacco? And if so, why can't this be rolled out in London? It's a bit of a specific regional one there, but maybe starting with the evidence.
Well, yes, I'll go back to Fresh and the Keep It Out campaign, and Ash has been involved in discussions with colleagues across London over a number of years now about why things can't be done in London. And, there's some very good trading standards colleagues across London who've been trying to make this happen, but it seems to have been difficult to achieve so far. let's hope that in the future we might be more successful, because actually you don't want to just tackle illicit in one borough. In London, there's a lot of movement across boroughs in people's work and living and all the rest of it. And illicit, if you tackle it in one borough, it'll just move to another. So yes, a cross-London approach is absolutely crucial. And the evidence is there from the work of Fresh and the Keep It Out campaign that you can actually reduce both demand and supply by a targeted regional approach.
Perfect. Thank you very much, Deborah. I think we may have largely covered the questions that have come in. So if anyone does have any, please do send them in. We touched a bit on, Deborah, you were saying about sort of tips and advice for gaining access to social housing providers, but this is certainly something I've heard, and one of the questions has also come in on this, saying they're finding it very challenging to engage with social housing providers. So do you think it's really sort of hitting on the points around the exacerbation of poverty and the effect this has on rental payments, sort of thinking about the housing provider a bit more as a selfish person, maybe, but do you think that's the sort of key lever there? Or do you think there are other tips for localities in terms of engaging housing providers?
Well, I certainly think the impact on the ability of people to pay their rent is important, and poverty reduction, and they go hand in hand. And probably, Robbie, you know as much as I do, because you've been working on this area, I know, and talking to tobacco control leads. And the more feedback we can get from tobacco control leads about what's worked and what hasn't in their area, I think is absolutely crucial. To some extent, it will depend on the receptiveness of your local housing providers and how it's structured, because obviously this is structured very differently in different localities. But the more we can find out about what's been helpful and what hasn't, and what messages seem to resonate best, the better we can do in future in trying to engage this sector, because it's something that is key to what we want to achieve going forward.
Yeah, we'd definitely echo all of that. And so, yeah, if any areas are finding that this is a particular priority at the moment and making ground in this, we really would love to hear from you. So, again, if you sort of can get in touch via that admin at smokefreeaction.org address, that'd be really helpful to hear. I suppose just on the housing side of things a bit, I know we had the question earlier about what sort of progress and interest we're making in this, and I suppose it has some sort of implications for the local setting too. As Deborah says, there definitely is national interest in this, and especially I think at sort of high levels within MHCLG. But I think the difficulties there are really about sort of trying to make this obvious as their agenda, and I think price is sort of the key motivator there. There are some interesting things at a national policy level, as we're sort of seeing. There was a recent white paper or green paper on social housing, and there was a lot of focus on joining up, and I think in a lot of organisations there's a lot of focus on joining up housing with health, and especially around indoor air quality. So that's sort of something we're looking at a national level. But I think you are starting to see that filter down to some of the housing associations and housing providers, but as Deborah says, it can be quite variable to what degree housing providers see this as a priority at the moment, but I think it's hopefully something we're going to see more and more of as we move forward. So I think with all the questions that are covered there, we can bring this webinar to a close. So
could I make one last point, Robbie?
Yeah, please do.
Sorry.
Deborah, please do.
Something I meant to make, a point I meant to make earlier. Sarah very helpfully pointed out that some measures seem to have better impact on reducing or reducing inequity. But what I would say is that doesn't mean we shouldn't do things which don't necessarily immediately reduce inequity, because they, as long as they still reduce absolute smoking rates. So yes, we want to reduce relative inequity, and we need to think about how we can improve the ability of the measures that we have in reducing inequity. So for example, with affordability, it's not just putting up tax, but reducing access to illicit. In the 1990s, tax went up very considerably during the decade, but because the illicit trade went up very even faster, actually it didn't lead to reductions in inequality in smoking rates. I think that's really important to recognise, that we want to keep driving down smoking rates and not just do measures that reduce inequity, because we want to reduce absolute rates, not just the relative rates. Does that make sense, Sarah?
Absolutely. Yeah, I mean, we want to see smoking prevalence continue to decrease in all socioeconomic groups. We just need to look for measures to sort of reduce inequity while reducing prevalence across the population.
Yes.
Brilliant. Well, thank you. I think that's a very good point to end on for both of you. So thank you very much, Sarah and Deborah, for those presentations. Really helpful. And thank you, everyone, for dialing in. As I said, please do get in touch with any feedback on the Health Inequalities Resource Pack. Do let us know about any ongoing work with groups with particularly high prevalence rates, or anything around housing, or sort of anything you'd like to let us know about sort of great progress you're making in your area on bringing down smoking rates in groups with high prevalence. Once again, this has been recorded, so we'll be uploading it to the ASH website, and we will send this round with our Prevention Green Paper submission and along with the slides and everything. So this will all be available on the ASH website, and we'll send links around. So thank you all very much. And yeah,